everyone, and thanks for joining in today and participating in this webinar. Today I'm going to talk about Skills Lab and that the fact that Skills Lab is not just for skills anymore. By the end of this presentation, you are going to walk away with 5 practical strategies that you can use to add clinical judgment to the activities both in your Skills Lab and in your simulations to balance out that education. Before we jump in, I just want to go over the learning objectives for the presentation. So by the end of this presentation, attendees will, number 1, recognize the components of Layer 3 and Layer 4 of the National Council of State Boards of Nursing, NCSBN's Clinical Judgment Measurement Model. They will identify opportunities to embed both the cognitive skills as well as the environmental and individual factors from CJMM into student skills practice. And you will understand the 5 strategies that you can use to implement clinical judgment into skills practice. And we're going to do that through the use of an example. So let's dive into the presentation. So first and foremost, we have to identify the problem, right? So before we can, work on a new strategy, let's talk about what the problem is that we're trying to solve. One of the biggest problems, and I'm sure you can guess by looking at the slide, is time, and specifically lack of time, right? So nursing classroom activities, nursing clinical activities, lab faculty, classroom faculty, clinical faculty, we all agree on one thing. There is not enough time in a nursing program to teach the students everything that we think they need to know to be successful practitioners. Really, there's barely enough time to teach them what they need to know for NCLEX success. And really, we know that NCLEX success is really only geared for safe practice in those first 6 months following graduation. So when you think about the pressure on nursing faculty, on clinical faculty, on laboratory faculty, on classroom faculty, the amount of content and information and skills that we need to get through to our students in the course of a program, it's pretty daunting, it's pretty intimidating. So, dividing time and focus between classroom, clinical, and skills often leaves gaps. And instead of students being able to see those 3 activities as interrelated and to make those meaningful connections, they tend to view those 3 areas as silos. They do their classroom activities and work. Typically, they go to class, they prepare for class, they may have some assigned readings. That's typically where most of their exams take place. They've got their clinical time, so they're going to be in their smaller groups. They're going to go out with their clinical instructor. They're going to work in a particular setting, probably assigned to a nurse with a nurse to work with, and they're going to take care of patients. And then lastly, they have the 3rd silo, which is their nursing skills lab or simulation experiences. So they're going to spend time in the labs with their peers, learning skills. Typically, they're set up as skills stations in many nursing skills labs. They sometimes have an opportunity or a requirement to come in and log some time doing practice on their own. And then also in most cases, most programs are also embedding simulations. So running scenarios, giving students roles and an opportunity to care for a patient in a simulated environment, whether that's mannequin-based simulation or standardized patient-based simulation. The challenge and one of the problems that we face is that students, and sometimes even us as educators or program developers, think of those as 3 separate components. And what we really need to do is find a way to thread meaning across all 3 of those so that students can start to see that those 3 things are connected. Another part of the problem, and this is maybe a little bit newer, I think the problem of time has been a long-standing problem in nursing curricula, right? There's just never enough time to teach everything that we want to teach. A more recent problem, if you will, is the change in the NCLEX examination that's coming right up. So April 2023 will be the rollout of the next generation NCLEX exam. So we're going to have the first cohort of students going through this new exam just in a few short months. And so in addition to the traditional exam items that, that we are familiar with and that we've long prepared our students for, there's going to be the addition of those new NGN items, and specifically those unfolding case studies, as well as those standalone items, the bow tie item and the trend item. So, you really need to start thinking about, what are we doing in our programs to integrate the clinical judgment measurement model into the curriculum? What's going in our classroom? What's going on in clinical? What's going on in lab and simulation that's helping the students to work on their clinical judgment, and to be able to start to prepare them, or in some cases, for your students who are going to be graduating in 2023, to get them to the place where they can be successful on that next generation NCLEX. So, speaking of the NCSB and clinical judgment measurement model, this I think is a good time in the presentation to just kind of take a moment to take a look at this measurement model, to compare it a little bit to the traditional 5-step nursing process that you see across the bottom. So that linear process of assessment, analysis or diagnosis, planning, implementation, and evaluation. I like this particular view of this because it overlays the nursing process onto the NCSB and clinical judgment measurement model, which you can see is quite a bit more sophisticated, a lot more information, a lot more complex. I really want to draw your attention in particular to layer 3 and layer 4. Layer 3 are the cognitive skills that the students need to work through while they're performing patient care. So recognizing cues, analyzing cues, prioritizing hypotheses, generating solutions, taking action, and evaluating outcomes. The color coding there is purposeful. So there is somewhat of an alignment to some degree between those steps in the nursing process and the cognitive skills in layer 3 of the clinical judgment measure model. And I think especially as we start to transition or start to incorporate that model into our classroom, into our clinical, into our nursing lab and simulation, this can be helpful to understand that the aspects of assessment and the aspects of recognizing cues can go together as that first step. And that analysis involves both analyzing those cues and prioritizing hypotheses. What do those cues mean? What do they point to? Of those things that they point to and those problems, which of those are priorities? What require action first? What is most important to take care of? Generating solutions is the step in the clinical judgment measurement model that aligns with the planning step in nursing process. We've identified problems, we've prioritized those problems. Now we need to generate solutions. What can we do to take care of those problems? Once we've generated a solution and we have an idea of what needs to happen, we have to take action as a nurse, right? So what are the things that we're going to do to generate solutions? And then evaluate those outcomes. Were the actions taken appropriate to solve those problems? One of the things that you'll notice that's significantly different about the clinical judgment measurement model versus nursing process, I mean, obviously just in looking at it size-wise, but the other piece of it is that it is much more circular in nature. So there's really a full circle going all the way around the outside. But then as you work through that layer 3, you'll notice that recognize cues and analyze cues continue to go around forming hypotheses, and you're going to continue to recognize cues and analyze them until you feel that you have an appropriate hypothesis. Then you're going to move on. Now I need to prioritize those hypotheses and I need to generate a solution. And now I'm going to refine and I'm going to look and I'm going to refine and really feel very comfortable about the set of hypotheses I have. Are they in the correct order? And what are the solutions that need to be put in place to resolve those prioritized problems? And then lastly, taking action, evaluate outcome. If the outcome isn't what was expected or what was desired, we need to go back and reevaluate and take additional or different actions. And that may mean going all the way back to the beginning and forming new hypotheses. So the point here is that this is very circular, both a large circle all the way around, but then within each step, circling around, refining before moving on to the next step. The other thing that's significantly different from the traditional 5-step nursing process is this idea in layer 4 of environmental factors and individual factors. So we all know, right, that you're not taking care of patients in a vacuum. And there are always going to be factors both in the environment and within the individual nurse that are going to impact the patient outcomes. So again, some examples that they show here is the environment itself, the pressure of time, how complex is the task, what is the what's in the medical record, what's in the patient's history that is going to make this problem in this patient specific and different from potentially the same problem in a different patient. So really you can think of the environmental factors almost as context, right? What is the context of the problem? And then also in layer 4 are those individual factors. What is the knowledge base of the nurse that's trying to take care of the patient with this problem? What if any is the prior experience? What is the level of expertise that nurse has? All of those things, again, sort of the environmental context, and now this is the PERS or the nurse-focused context. Those things are also going to impact the solution that gets generated, the actions that are taken, which actions are taken, how efficiently they're done, even going back to analyzing cues and prioritizing hypotheses, analyzing cues to come to a suspected problem or a hypothesis. That experienced nurse who's maybe seen this set of cues many, many times is going to get to that hypothesis that is accurate a lot more quickly than the nurse with less experience, less expertise, who doesn't necessarily know what those cues mean and has a harder time analyzing them and may take a couple of times to form that hypothesis. So it really is the context in which the care is happening. And as you look at the nursing process piece, it really doesn't account for that. When you're thinking about, well, how does this, why does this matter? Or what does this have to do with what's going on in my skills lab or in my simulation? Really thinking about, in particular, those environmental factors. So you're starting out with your first semester students, they're brand new. We want that environment to be super, super transparent, super easy, super clean, allowing them to really, really focus on the task at hand. But as your students start to advance and they move through your program, they're increasing in their experiences. They should be increasing in their knowledge base. They should be increasing in their level of expertise. And now you can start to manipulate those environmental factors to start to layer in some additional challenges and some activities that are going to require them to really practice that clinical judgment. So putting that layer 4, really considering that as you build both your skill stations and in particular your simulations is going to be really important. So as I alluded to as we started this presentation is this idea of silos. And I think it's really important to understand that to embed clinical judgment skills and to start to have your students understand those individual components of clinical judgment, to understand the context within which they're working, and to start to be able to transition through those steps of those cognitive skills of clinical judgment smoothly. We have to unsilo our programs, right? So it can't be, this is what I do in the classroom, this is what happens in clinical, this is what happens in the lab, whether it's the nursing lab or the simulation. We really need to make sure that we're threading that clinical judgment through that we're helping the students to see the connections between the classroom and the clinical and the skills lab. So, think about how often we present content. So you come to my class this week and we're going to be talking about lower respiratory disorders and how to care for a patient with lower respiratory disorders. And, maybe we use an exemplar of a bacterial pneumonia and maybe, chronic obstructive pulmonary disease. And, I deliver a whole bunch of content. Maybe we've had reading, we do class, maybe we have an in-class case study, things like that. Now my students go to clinical, and ideally, hopefully, they go to clinical, and at least a few of the students I'm able to assign to care for a patient who has one or both of those disease processes. Great. And then maybe I also have lab going on that week, right? So in lab, maybe we're doing our IV therapy skills, and I'm showing my students how to prime an IV and run a secondary piggyback of an antibiotic. Or maybe we're learning how to do IV push, and it's an injectable steroid for someone with an exacerbation of their chronic obstructive pulmonary disease. Can our students put those three experiences that week together and start to think about that patient as a whole and apply that clinical judgment? So thinking about the aspects of the disease process in the nursing care that I learned in the classroom, what did I see in clinical? What did that patient look like? How were they acting? What were the problems that had manifested? What were the things that were being done to care for that patient? And then taking those activities from the skills lab. What role does the IV antibiotics or the IV steroid have in the care of that patient? What would the expected outcomes be when I give them that IV antibiotic or I give that IV steroid? What assessments would I want to do? What would I want my patient's outcomes to be on day 1, day 2, day 3 of those different therapies? So that's more than just learning how to prime the tubing, learning how to thread the tubing through the pump. More than flushing the IV. Of course, those are skills that the students need to learn, but we need to stop teaching those skills in a vacuum, and we need to associate those skills back across to, well, what did you see in clinical this week? Did any of your patients get any IV therapy medications? What were you expecting to have happen? Why were they taking those medications? What were you monitoring your patients for? Things like that. And then bring that back to the classroom. Have you studied about this particular disease process or this particular disorder in class? What did you learn about the pathophysiology? What happens to the patient when they have this particular problem? What are the things you should be looking for? What findings would you expect? So we really need to learn how to tie those things together. And once we can do that and we have students thinking in that way, it becomes a lot more intuitive for them to start to use those cognitive skills in that clinical judgment measurement model. So what are these 5 strategies? How can I get my students thinking about clinical judgment when they're in the lab, right? So many times we're in the lab, and, if it's anything like, the way we taught in our program, we had simulations that happened at certain points in the semester. Usually there was a mid-semester couple of days where they came back out of clinical and did simulations, and then there was at the end of the semester. And then in between, they had scheduled skills labs where there were particular skills that were taught at various levels in the program, and they would come in and we had stations, and they would learn how to do those skills in the stations. So what can we do? And I think that's a pretty common sort of schedule or setup for a lot of programs. So what can we do thinking about those two sort of lab scenarios? What can we do to embed that clinical judgment into those activities? So here's the strategies that I would propose. First and foremost, anytime you have your students working in the lab, whether it's a simulation or you're doing multiple stations of skills, use a patient scenario. The patient that they are taking care of, even if it's the simplest of skills, making a bed, doing a bed bath, learning how to put an IV in, learning how to infuse an IV medication, checking blood pressure, or vital signs in general, whatever it is, use a patient scenario. The patient should always have a name. The patient should always have a diagnosis. The patient should always have some sort of medical record that the students can look at. It doesn't need to be super complex or super expansive, but I always used to say we shouldn't be doing skills in a vacuum. The students should always be continuing to layer on the things they learn week 1 to week 2 to week 3, semester 1 to semester 2 to semester 3. So every time they're practicing a skill, are they walking into the patient's room? Are they doing their hand hygiene? Are they introducing themselves appropriately? Are they identifying their patient? Are they having conversation with the patient about what they're going to be doing, why they're going to be doing it? So always use a patient scenario, even when it's just skills practice, because really there's no such thing as just skills practice. Every intervention that our students and then eventually our graduates are going to be doing is going to be on a patient. So start them out thinking that way from day one. Second strategy is that every patient should have a specific need. Make your students understand, encourage your students to understand, why am I doing this skill, right? So if it's a skill of placing, of catheterizing, let's say it's catheterizing. We used to have a whole week in our lab, in our fundamentals, where the students had to learn how to do an intermittent straight cath or do an indwelling catheter on both a male and a female. We had the benefit of having a very nice, well-equipped lab. We had lots and lots of mannequins in beds. But here's the thing. This needs to be more than just, how do I open that kit? How do I set up that sterile field? What order do I do things in? How do I not contaminate? And yes, that's a lot. That's a lot for students. So I'm not suggesting that we make it incredibly complex in terms of a patient having a need. It can be as simple as, here's a patient, this was their admitting diagnosis, this is their name, they have a wristband on, they have a very brief scenario, very brief medical record. It can be something as simple as a post-operative patient who was unable to void. It's been more than 8 hours. They need to have an intermittent straight cath to empty their bladder because they're becoming uncomfortable. But have a specific need so that when your students go in, they're able to connect the skill to the patient problem. And so then you start to be able to recognize those cues. Well, what are the cues? Time. How much time has gone by since they last had any urine out? And typically, if it's a post-op patient like I described, what time did that catheter come out, right? So it's going to get them thinking, if I'm taking report on a patient from the recovery room, do they have a catheter? Yes or no? Oh no, we took that catheter out. What time did you take it out? Letting your students understand that that's a really, really critical cue. That's a piece of data that they have to have. So they're going to write that down. How much time has gone by? Verbally asking the patient if they're uncomfortable. Are they having pelvic pain? So getting that subjective data from your patient, and then that objective data. Well, what would you do objectively before you put that catheter in? Well, I'm going to palpate. Is the bladder up above the pubic bone? So having them show you, well, where would you palpate? Why are you doing this? What does this represent? Instead of having them just fly in and start opening that catheterization kit. So have your patient have a specific need. The third thing that you want to do is align those steps of the clinical skills in layer 3, those cognitive skills, line them up with each activity your patient is doing. So just like I did, what are the cues you're going to look for that are going to indicate that potentially a catheter is needed, or a blood pressure recheck is needed, or a medication should be administered? What are the cues that they should be recognizing? And then how are they putting those cues together to formulate what the problem is? So I've got a post-operative patient, perhaps. Their blood pressure is elevated. Their heart rate is elevated. I went to have them do their incentive spirometry and they're really unwilling to move around in the bed. There's a facial grimace. Those are all cues to recognize. Now I'm going to analyze those and I'm going to try to come up with a hypothesis. And that hypothesis is probably that the patient is in pain and that they need some pain medication, right? So where does that fit in the priority of things? That's pretty high for a post-operative patient. So what is my solution? I need to generate a solution. I've got to go into the EMR. I've got to see what pain medication is ordered. I've got to understand or know when was the last time they had pain medication. And not just when was the last time, how did they respond to it? Did they get relief? Did they not get relief? Because maybe I can just repeat the order if it's time, but maybe enough time hasn't passed that I could give that medication again, or enough time has passed, but the last time they had it, it didn't help. So they need to start to generate a solution. Once they have a hypothesis, they've prioritized it, they've generated a solution, then they can take their action. And then that often really is the skill, right? So whether it's administering a medication, whether it's putting a catheter in, whether it's rechecking a blood pressure, whatever that is, that action is taken. But look at all of the thinking and processing and judgment that has gone on before that. And then the evaluation. When do I evaluate, right? So I've got somebody with a distended bladder, I put a catheter in. You can evaluate immediately. Do they feel better? Is the bladder no longer palpable? How much urine did you get out? You can measure it. What color is it? Things like that. Giving someone a medication. Well, if it's a pain medication, it depends on the route, right? So you can talk to your students about that. Well, what route did you give? When would you expect them to start to feel relief? What are the questions you would ask the patient? If it's a blood pressure medication, needing to understand the mechanism of action of that particular blood pressure medication. What should I be looking for? When should I be rechecking the blood pressure? So doing that evaluation. So it's really critical to help your students to understand that every action that they take aligns to one of those cognitive skills. Eventually, and we know this as experienced nurses and as experienced faculty, we don't think of these things as individual steps. We don't say, I'm recognizing cues. Now I'm analyzing cues and making a hypothesis. And now I'm prioritizing. We roll those all together into seamless patient care. As students, I think often we expect that they're just going to be able to jump from that. They're going to be able to jump from what they learned in class and they go through their skill stations, and then all of a sudden they're going to be able to do all of that. We're not showing them how to take those apart bit by bit and talking through each step. Number 4 is including environmental and individual factors in skill station. And I talked about this a little bit in the beginning. This really can be customized. And I think what you really need to look at is, what is the level of my students? What is their knowledge base? How much expertise or lack of expertise do they have? And then you're going to layer in those contextual pieces based on that. Your low-level students, the context should be very, very simple. As simple as vital sign check on a patient who comes into an office for a physical exam, or a well child, right? Just very, very clean, very basic. All the way up to, you've got maybe your senior level student, and you've got a patient who has a known anxiety disorder, who couldn't take their medication because they had to be NPO for a surgery, who's now post-op, and they've got super elevated blood pressure, super elevated heart rate, really struggling to verbalize because of their anxiety, or is it pain? I'm not really sure. What direction do I need to go? What are the hypotheses, and how do I weigh those against each other to formulate or to generate a solution? And then the last strategy is timeouts. And I like to call these timeouts because so often, I think both our students and sometimes as faculty, we want to just get the students through, get through the simulation, get through the skill station. We need to get this done. This goes back to time. And I think it's important to take time out and to go through each of those steps. What things did you recognize that might have pointed you to a problem? There's all kinds of data here that you can collect on this patient. What is relevant and critical? What can you leave alone? How do you take those things that you think are relevant and clinical? When you think about them, when you analyze them, what are you thinking? Take the time to go through each step. So I want to talk a little bit more about that in terms of an example. Okay, so because I think it's super easy for us to say, well, okay, there's these steps, and the students are thinking through these steps, and they're going through this, but are they really? Are they understanding that I'm recognizing cues, I'm analyzing cues, I'm hypothesizing, I'm trying to come up with a problem? Or are they just trying to memorize stuff, right? Well, every patient with this, I do this, and what they're going to find, and what we all have learned, both as nurses ourselves and then as faculty, it can't be about memorization. There's too many steps for nursing to ever be about memorization. They really have to start to think deeper than that. They have to think conceptually, and they have to really be able to apply judgment. So the example that we're going to use today is administering medication. This is a critical must-know skill that is taught in every single nursing program. Every single nursing program teaches medication administration, and most of our students hopefully have at least some opportunity to actually administer medication to patients in their clinical setting. I know from my experience personally, when I was teaching clinical, sometimes I was very limited, just because of hospital policies or institution policies, as well as how much time it actually took with new nursing students to administer medications. I was limited to how many students I could, legitimately work with medication administration on any given clinical opportunity. So they didn't get a lot of opportunities to do it. So this is really something that you want to embed both into your skills lab as well as your simulations. But this is a great example that you can use in terms of clinical judgment. So, here we've got our patient scenario, right? So this is patient Albert Davis. This patient happens to have heart failure and he's admitted with an exacerbation of heart failure. So he's going to need to get some Lasix. He's going to get a 20 milligram direct IV dose now. So a stat dose, a one-time dose. He's going to be on some increased oxygen, 4 liters by nasal cannula. And he's going to need to have a stat potassium level in 4 hours, right? So you can even start right there with your students, so why these medications? Why these particular treatments? What about his problem would make you think that these are appropriate treatments, right? Because we know as nurses, we have to be always looking critically and using our clinical judgment. Is this an appropriate medication, Lasix? Is this, what about the potassium? Why is that important to draw? What should I be looking for? Should I be looking for it to be elevated, or should I be looking for it to be depleted? Our students need to learn to start to read medication orders and understand, why were those things ordered? Can I make sense of them? So that you can start, right there. So that's step one. Always have a patient scenario, right? And then the practice, always making sure that there's a specific patient need. What is it, that we're doing? And maybe for this patient at a fundamental level, it's just about getting their vital signs, right? This is a patient with heart failure. What is the temperature? What is the pulse? What is the respiration? What is the oxygen saturation? Why is that important in this patient? What might be going on in a patient with heart failure with their blood pressure? Would I expect it to be elevated, or would I expect them to have hypotension? What am I going to expect when I listen to the heart? Where should I be listening to the heart? All of those things. Going up a little bit, you've got your med-surg patients. So we want them to have all of the practice that the fundamental students are doing, but now thinking about medical surgical. Well, now I know more about heart failure. Why is it important to be assessing pulses in the feet? Well, what does that have to do with heart failure? Why am I, pressing on the tissue on that posterior aspect of the tibia? What am I expecting? What's the reason for this, right? So it's not just about memorizing, someone with heart failure, I have to check their vital signs. I have to listen to their heart. I've got to palpate their feet. I'm pressing in. I'm looking for edema. We can't just memorize the steps. You need to ask the student, why are you doing that? What data are you collecting? Cues are you recognizing? How are you putting those pieces together to generate a hypothesis? So in a patient with heart failure, the hypothesis is maybe they have too much fluid on board. Their fluid is okay. Why am I giving furosemide? What is furosemide? It's a diuretic. What's a diuretic? What's the intended action? What do I expect to have happen? What data should I be collecting after I give the furosemide? So you want to start to layer in that type of clinical judgment. And then at all levels, when you're practicing, always practicing within a patient scenario, always as a student, identifying yourself, hand hygiene, identifying your patient teaching as they go through their skills. And that's one of the hardest things for students. They are so focused on that skill practice and doing that checklist and making sure that they've got all those skills. And absolutely, they need to practice that. But once they're comfortable with that, they need to do at least those last couple of practices with the scenario, going through the whole process, doing that patient teaching piece. So as we talked about, that third strategy is the cognitive skills, aligning each and everything that your student does, thinks, says, acts upon with the cognitive skill in layer 3. When you check the blood pressure, you're recognizing cues, you're looking for that data. When you assign meaning to it, you're analyzing it. What is the priority? If the blood pressure is 138 over 88, yes, that's slightly elevated. Have they had their blood pressure medication? So this is the conversation that you want your student to actually be having out loud, right? Because you want to know what they're thinking. Are they thinking these things? Or are they just like, okay, 138 over 88, I think I got it. I'm watching the sphygmomanometer. I think I've got that right. I need to record it. And they're never even thinking, what do I think the blood pressure should be in this patient with heart failure? They're in with an exacerbation of heart failure. They're going to be getting a dose of furosemide, which means they're probably fluid overloaded. I would expect their blood pressure to be what? Elevated, and ask them why. Often, I think we rely on the classroom to do this, but all of this needs to carry over into our skills lab. It's not just about learning how to check the blood pressure. Of course, that needs to happen, but put it into some context so that your students can start to make those connections. So generating solutions and taking actions. Well, if the blood pressure in our patient with heart failure is significantly elevated, we're going to administer medications, right? So is it that one-time dose of furosemide that's needed? Maybe they haven't had their routine medications, their 8 o'clock or a.m. medications for blood pressure, and they need those. So taking those actions and then evaluating those outcomes. So making sure that every step of the practice, whether it's a skills station or every step along the way when they're doing simulation, that in the debrief, you talk about this. Well, I saw you check the blood pressure. What were you checking for? And they'll tell you blood pressure. Well, what did you expect it to be? What did you think about the number? Was that what you expected or not? Do you think that amount of furosemide was appropriate for that blood pressure? So all of those things, and they'll look at you initially like, I just checked the blood pressure, but we want them to start thinking in this way. And so using these, really teasing out these individual cognitive skills is going to help them with that process. Step number 4 in the strategy we said was to start to dial in both those environmental and individual factors, in particular the environmental factors, right? So is this in the simulation, is this a patient who is very very willing to have their blood pressure checked? Is this a patient who it's easy to obtain a blood pressure on, versus is this a patient who is maybe not happy to be in the hospital, not wanting to participate in the care? Is this a patient who's nonverbal? Is this a patient who has a significant disability where it's challenging to check the blood pressure? You can layer in all of those different environmental factors to change some of the learning objectives and to allow your students to think through, how can I go through this process of caring for this patient when there's these different things going on? How much time do they have, right? So I've got my fundamental student, I'm going to give them 15 minutes to go in, hand hygiene, introduce themselves, identify their patient, and check a blood pressure. And that's probably just enough time, right? My senior level student, I'm going to give them 4 or 5 tasks in that same amount of time and really watch how they use their time, collect their data, analyze, put things in priority order, and enact those things, take action based on the order that they prioritized, right? So really watching them to determine, if I've got my patient who comes in with heart failure and they go in and they take the blood pressure and it's elevated, maybe they listen to lungs and they're really hearing some adventitious sounds in the lungs. They know this person's got a lot of fluid on board. At that time, do they have enough information to stop, to get that ordered dose of furosemide and go ahead and give that? Have they prioritized that based on what they've collected so far? Or are they missing that and they're going through and filling out the whole nursing assessment sheet because in their mind, that's what you do first, right? That's clinical judgment. At what point do I feel like I have a plan, but there's a finding now that I need to clinically think about and judge and say, this needs to divert me. I need to go in a different direction because I've now moved that priority above this and I need to take action on this. So being able to use the environment to, and specifically time or list of skills to sort of push your students on that. And again, always considering when you're manipulating the environment, whether it's time pressure, whether it's complexity of the task, whether it's something that has to do with the patient, right? Are they non-English speaking? Like I said, are they nonverbal? Is there some significant disability that's going to make it more challenging to give that care? You really want to think about the individual factors of your students, right? What is their knowledge base? What experience have they had so far? What is their level of expertise? So we really need to consider those things. And then lastly, as I talked about, is this idea of timeouts. In general, I would say both in skills lab and simulation, slow down. Following these strategies, 1, 2, 3, and 4, is going to make everything take longer. And it may mean that your students don't rotate through these stations 3 or 4 times. It may mean that they only rotate through them once or twice. But all of that additional layered learning is going to be invaluable to your students. So each round of practice may take longer. Each simulation may take longer. And this really is going to happen in the debrief. And you know, if you do reading on simulation and you look at the standards, you know, the Annexel standards with simulation, your debrief should take twice as long as the time it took to run the scenario. So always think about that when you're planning your simulations. If you run a 15-minute simulation, you should be debriefing for 30 minutes. If you run a 30-minute simulation, you should be debriefing for an hour. Take the time to do that. That's where the learning happens in simulation. But that's okay that it takes longer. Again, all of those additional layers of learning, it's definitely going to be worth it. One of the things that happens in timeouts that can be super effective is encourage your students to verbalize their thought processes out loud. This is a lot. This is a big one for students. This takes a lot because they're super anxious just about verbalizing when they're unsure of what they're doing, unsure of if what they're thinking is right or wrong, how are they going to sound, what are their peers going to think, what are their faculty going to think. You know, I used to say to my students all the time, practice it now in front of us before you have to do it in front of your patients. The thing that makes the patients and the family the most nervous is when the nurse goes in and gives care and is silent, because what do they all think? Something's wrong. Right? It could just be that the nurse is brand new, is a nervous wreck, has never done this before. But to the patients and to the family, your quiet means something's wrong. So students need to be able to start to learn to talk through things, talk out loud while they're taking care of the patient. And what better place to do this than in simulation, than in your skills lab? Have them talk through that. Well, I think I'm going to check the blood pressure because I know this patient's in with heart failure. I've looked at the MAR. I know they're on some blood pressure meds. Let's see where we're at baseline. I know I have to give a diuretic. I'm going to take a listen to the heart. I'm going to check for edema. Why am I doing these things? You know, have them do that out loud. It's hard and you really have to push them, but push them to do that. Challenge them to be inquisitive. Challenge them to finish their thoughts. Don't worry about them getting every step perfect. Worry more that they understand why they're doing what they're doing, what they expect to have happen based on the actions that they take, what to do if that doesn't happen, and when and how to change the steps, when to change the order, when to divert from the original plan and take a new plan. So the perfection of the steps, that will come, but why are they doing it? What do they expect to have happen? They shouldn't be practicing skills or performing interventions in a simulation in a vacuum. If I take someone's blood pressure and then I give them a medication, what do I expect to have happen? And how am I going to check on that? And what do I do if it doesn't happen? That's what you want them to be verbalizing through. And that's really the critical piece of the timeout. So again, with your strategies, always prevent skills within the context of a scenario. Never just allow your students to practice the skill. Make sure they're taking care of a patient who has a specific need. Align every step of a skill or a procedure and interaction to one of the 6 cognitive skills in layer 3. Start to dial in those environmental contextual factors depending on who your students are and what their individual factors are, and use those timeouts. Really, really work on getting your students comfortable talking out loud, thinking out loud, I like to call it. Let us know what you're thinking. Tell me why you're doing what you're doing. What are you thinking? Doesn't matter if you're right or wrong. We're all in the same boat. We're all here to support you. This often works well too as a group activity. You know, when they get stuck, I always call it pass the baton. You know, pass the baton to the next person. Have them help you, that kind of thing. What we have, and I'm going to leave this slide up and you can actually go ahead and use your phone and take a picture of this QR code. We have a free guide and a template that you can use to help you when you're planning either your skills labs, your stations, or you're planning a particular scenario. This guide will really help you to align the different skills with these cognitive skills in the clinical judgment measurement model. So it really is a template that you can use. And the nice thing about this is that you can use it across your entire curriculum at every level of the program. This is great documentation for you to keep. Not only is it going to help with your student evaluations at each level, this is going to be great documentation for accreditation. When the accreditors come and they want to talk about, well, how do you tie what you're doing in your skills lab and your nursing lab or your simulation to your program outcomes? How are you integrating clinical judgment in the lab environment into your curriculum? You can pull these out. These are our integration sheets. These are the simulations we run at semester 1, semester 2, semester 3. Here's all of the different things that go on in the simulation broken out, aligned to these clinical judgment measure models. And then also there's the timeout talking points. So we actually have one that we'll share with you, which is our patient, Albert Davis, who comes in with his exacerbation of heart failure. So you have one that you can use to practice with or use as an example. And then there's an opportunity for you to download the blank one so that you can integrate those into your own simulations or practice skills. So that is all that I have for this webinar. I hope that there's some take-home message, something that everybody can use from this. And thank you so much for listening.